सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् न त्वहं कामये राज्यं न स्वर्गं न पुनर्भवम् कामये दुःखताप्तानां प्राणिनां आर्तिनाशनम्। प्राणियों के दुख को हरण करने की क्षमता दे ईश्वर हमको, यही हम इसमें प्रार्थना करते हैं।
So today's CME continues our regular academic series aimed at updating, refreshing and fine-tuning our clinical practice. The topic for this morning is fibromyalgia, myth or reality. As you know that fibromyalgia is often a diagnostic challenge. Patients come with widespread pain, fatigue, sleep disturbance, and we frequently wonder, is it organic or is it psychological? Or is it overdiagnosed or underdiagnosed? This session has been specially designed to help us separate myths from fact and learn practical clinical based approaches for our day-to-day practice. So we are honored to have with us a speaker, Dr. Santhosh Kumar Tiwary, MBBS, MD, Anesthesiology, Fellowship in Interventional Pain Management, and he is practicing anesthesia and pain specialist at Majestic Clinic, Taramandal. Dr. Tiwary has extensive experience in the field of pain medicine and has been managing a wide spectrum of chronic pain conditions, including fibromyalgia, with a balanced approach integrating pharmacological intervention and rehabilitative strategies. So now I request Dr. Santhosh Kumar Tiwary sir to kindly come to the podium and deliver his talk on fibromyalgia, myth or reality. Today
I am here to throw some light on fibromyalgia, whether it is myth or a reality. In this discussion, we'll try to find out whether it is a reality or a myth. There is a lot of confusion regarding fibromyalgia, not only among patients, but also among doctors. Doctors are also equally confused whether it is a neurological symptom, psychiatric symptom, or is there something organic. So, and fibromyalgia is most important cause of widespread pain, affecting about 2 to 12% of general population. In India, the average is about 2 to 8%. And females are more affected than males, about 3 times more. The commonly affected age group is 5th to 7th decade. What is fibromyalgia? Fibro means tissues of tendons and ligaments. Myo means muscle and algia is pain. So, is fibromyalgia a disease of tendon, ligament, muscles? The answer is no. Fibromyalgia is not a musculoskeletal disorder. It is a complex syndrome characterized by pain amplification. Pain amplification is a very important. So the answer is no, fibromyalgia is not a musculoskeletal disorder. It is a complex syndrome characterized by pain amplification, musculoskeletal discomfort and wide range of systemic symptoms. Pain amplification is very important. Actually, the mechanism is central sensitization. The patients with fibromyalgia display diffuse hyperalgesia and allodynia. Hyperalgesia means a mild pain stimulus will cause exaggerated response. The patient will perceive the pain as severe. And allodynia means that even a touch sensation, a touch stimulus will produce a painful response in the patient. The pain is not confined to a specific region, but it is vague and ill-localized. One of the key features is increased sensitivity or hyper-responsiveness. Fundamental problem is with pain or sensory processing and not peripheral. अब यहाँ नहीं change हो रहा है. There is increased activation of second order neurons in the spinal cord. Increased activation of second order neurons in the spinal cord. Patients with fibromyalgia show an elevated levels of biomarkers associated with pain, especially glutamate and substance P in the CSF. Glutamate and substance P are located in the dorsal horn of the spinal cord, and there, due to some error or some mechanism, the secretion of glutamate and substance P is elevated. They also show an elevated levels of endogenous opioids. That is why opioids are not having good response in treating such patients, and serotonin level is low. Central sensitization of nociceptive neurons leads to nerve impulse being perceived as more painful. This is hyperalgesia, as we mentioned. Recruitment of wide dynamic range neurons leads to non-nociceptive impulses being perceived as painful. That is allodynia. It means if, as in the previous lecture also I mentioned, in central sensitization what happens, even if the stimulus is gone, the pain stimulus is not there, but the system has memorized it as a stimulus, and in long term the adjacent nerve endings also are recruited, and they also act like painful stimulus, carrying painful stimulus, and produce allodynia. That is why even a touch sensation will cause a painful stimulus. So let us recapitulate this mechanism. First, impulses from the afferent depolarized dorsal horn neurons. Then extracellular calcium and nitric oxide diffuse into neurons and cause exaggerated release of substance P and glutamate. This results in neuronal hyperexcitability, and finally a pain signal is sent to the brain from the dorsal horn. So in fibromyalgia, dorsal horn neurons become hyperresponsive to nociceptive and non-nociceptive somatic stimulus. This is known as central sensitization and is thought to result in hyperalgesia and allodynia. Now, what are the clinical features? The patient presents with pain. The most common presentation is pain, and pain all over the body. It's very difficult to localize. Stiffness, the morning stiffness, patient complains morning stiffness that can last for 45 minutes to even 4 hours. And fatigue is always there. About 80% of patients with fibromyalgia complain of tiredness and fatigue all over the day. Cognitive dysfunction is there. It may range from difficulty in reading books to short-term memory loss. Affective disorders are there. Up to 40% of patients with fibromyalgia have associated mood disorders like depression and anxiety. Sleep disturbance. The patient wakes in the morning with unfreshening sleep and insomnia. It can present as insomnia also, or unfreshening sleep also. There are a lot of systemic disorders which are usually associated with fibromyalgia. It may be non-dermatomal paresthesia. Non-dermatomal means paresthesia is also very vague and it cannot be localized to a nerve distribution area. Temporomandibular joint syndrome, hypermobility syndrome, restless leg syndrome, rheumatoid arthritis, systemic lupus, the list is long. Dysmenorrhea, interstitial cystitis, female urethral syndrome, vulvar vestibulitis, and premenstrual syndromes. Irritable bowel syndrome is very common. The patient comes with irritable bowel syndrome and pain all over the body and sleep disturbance, mood disorders. This is the commonest presentation we have seen. Esophageal dysmotility is there, heartburn or regurgitation or something like epigastric pain. Mitral valve prolapse is an organic disease, and patients usually with mitral valve prolapse usually have this type of presentation. mitral valve prolapse है तो उनको डिप्रेशन हो जाएगा, अरे मेरा तो हार्ट खराब है, और उसकी वजह से this sets in a cycle of depression and mood disorders and sleep disturbance and everything. Ocular disturbance, anxiety disorders, Raynaud's phenomenon. Raynaud's phenomenon is another common complaint. The patients come with the complaint that डॉक्टर साहब ठंडा थोड़ा ही बढ़ता है, मेरा हाथ पैर बिल्कुल ठंडा हो जाता है, रेड हो जाता है. तो this is a very common presentation. Hyperventilation. The patient comes with hyperventilation and is usually mistaken with some respiratory disease. Cognitive dysfunction is there. So let us come to the diagnosis. In 2010, American College of Rheumatology laid down the criteria for fibromyalgia, diagnosing fibromyalgia. A patient satisfied diagnostic criteria for fibromyalgia if the following three conditions are met. Number one is widespread pain index WPI more than or equal to 7 and symptoms severity score, that is SS scale score, is more than 5 or equal to 5, or WPI 3 to 6 and SS scale score more than 9. Symptoms have been present at a similar level for at least 3 months. This is very important. We cannot diagnose fibromyalgia in the 1 week or 2 week duration. It must be lasting for more than 3 months at the same level, same severity, same complaints, everything. So the areas of tenderness or pain are distributed like shoulder girdle left and right, upper arm left and right, lower arm left and right, hip left, hip right, then upper leg, lower leg, left and right, jaw left and right, chest, abdomen, upper back, lower back and neck. These are all 19 areas and the score should be at least 11 out of 19. 11 places should be having pain or tenderness. Actually tenderness was included in the criteria of diagnosis previously, but in 2010 American College of Rheumatology guidelines, only complaint of pain is sufficient. Tenderness is not necessary to be there. SS scale score, this can be assessed on 3 criteria: fatigue, waking unfreshened and cognitive symptoms. For each of 3 symptoms above, indicate the level of severity over the past week using the following scale: no problem 0, 1 is slight problem, 2 is moderate and 3 is severe. Considering somatic symptoms in general, indicate whether the patient has 1, 2 or 3 score in SS scale score. So widespread pain should be of more than 3 months duration, tenderness at least in 11 points out of 19 points, and the patient does not have any other disorder that otherwise explains the pain. If the pain is explained by some other disease, that is the diagnosis, that then we cannot go for fibromyalgia. This is a checklist we can give to the patient or fill by ourselves. All the parts, they contain, every part contains 1 point. There are 19 points and we have to calculate how many painful or tender points are there. The common points of tenderness are, in the previous guideline actually, we used to see these points: occiput, lower cervical, paraspinal, trapezius, supraspinatus, second costochondral junction, 2 cm distal to lateral epicondyle, upper outer quadrant of buttock, just posterior to the greater trochanter and knee. What investigations can we do for diagnosing a case of fibromyalgia? Actually, there is no investigation specifically because the diagnosis is on the basis of exclusion. We exclude other diseases and then we go for clinical examination and we take the clinical examination, clinical findings in consideration and diagnose fibromyalgia. We can have these exclusion investigations like CBC, ESR, C-reactive protein, RA factor, anti-nuclear antibody, thyroid function test, LFT, KFT and creatinine phosphokinase. So, what are the differential diagnoses we can have with fibromyalgia? Hypothyroidism. If we rule out hypothyroidism, we can go for a diagnosis. Then myopathies, rheumatoid arthritis, connective tissue disorders like SLE or Sjogren's disease. Then how to manage a case of fibromyalgia? Actually, it is a multidisciplinary approach. We have pharmacotherapy, some non-pharmacological treatments, physical rehabilitation, psychotherapy and some interventions. Role of intervention is not much, but in cases of refractive case of fibromyalgia, we can go for some interventions. We will discuss later. For pharmacotherapy, we have recommendations: first line, second line, third line. First line drugs are pregabalin, duloxetine, TCAs like amitriptyline and milnacipran. Non-pharmacological treatments are aerobic exercises, cognitive behavioral therapy, patient education, and second line approach is tramadol, fluoxetine, citalopram. Non-pharmacological measures in second line include strength training like isomeric exercises, then acupuncture, hypnotherapy, relaxation, biofeedback. Third line is chiropractic. Some patients use some chiropractic specialists are there, but I don't support that method of treatment. Massage therapy, massage is useful. Ultrasonographic massage is very useful, and electrotherapy like nerve stimulation with TENS therapy we can do. Not recommended are opioid analgesics. As we saw earlier, there is endogenous opioid, raised level of endogenous opioid, and therefore the patient is refractory to opioids. Then corticosteroids is not recommended, NSAID is not recommended. There is no inflammation. Actually, the problem is in the central system, the processing of the pain pathway. There is no inflammation. Inflammation is not the cause of pain. So it's a no role. Benzodiazepines have no role. Melatonin, calcitonin, thyroid. Melatonin can have some role for developing neuroplasticity, but it's not proved. Calcitonin, thyroid hormone, guaifenesin, and tender point injections are usually not recommended. 3 drugs are FDA approved, although we use a long range of medications, but only 3 drugs are FDA approved: pregabalin, duloxetine, and milnacipran. Please see it carefully. The question is out for quiz. We can have doses and evidence, strength of evidence. Evidence-based studies show 1A evidence for amitriptyline, very useful, and all of us use it very commonly. Amitriptyline 10 to 50 milligram. Drugs recommended for pharmacotherapy are amitriptyline has very good evidence. Duloxetine has a very good evidence. The dose of amitriptyline is 10 to 50 mg. We start from 10 and then go slowly to increase the doses. Duloxetine is 30 to 60 mg, although I start from 20 mg only, and many of the patients respond well. FDA approved hai. Duloxetine is FDA approved, and long term efficacy is good. The evidence is 1A. Milnacipran again 1A, 25 to 200 mg. 25, start from 25 and go slowly to increase the doses. This is also FDA approved. Then pregabalin, all of us are using. Gabapentin 1200 to 2400 mg. Cyclobenzaprine is actually not much helpful, but in acute phases when the patient comes for the first visit and very anxious, then we can have cyclobenzaprine with one of these drugs. Fluoxetine and paroxetine, they are mainly antidepressants, but sometimes they are helpful in these patients also. Tramadol is good. Tramadol, although evidence is 2B, but the patients respond well and patients are happy with tramadol. The problem with tramadol is itching, generalized itching and nausea, sometimes dizziness also. So we have to titrate that. Non-pharmacological approach is also very important. We have to have a good counseling session with the patient, and we have to make the patient understand that only doctor is not responsible for your health. You are also equally, rather more responsible, and you have to take care of yourself. You have to think positively and have a good exercise and other like swimming and cycling, and the patient should socialize with his colleagues and all. Then interventions. Interventions are usually not needed, but in some refractory cases where there are some bands in muscles somewhere, then we can use lidocaine infiltration in the fibrous bands, and that gives a good relief. And we can even have a hydrodissection with only 5% dextrose in the bands. This releases the band, releases the muscle, and tightness, stiffness is gone. Then ketamine infusion, you have to dare for this treatment. Ketamine infusion in doses of 0.5 mg per kg per hour can be given 1 week apart. Weekly, we can repeat it weekly for 4 to 5 sessions. And the idea behind this is to break the cycle of central sensitization by blocking the NMDA receptors. NMDA receptors in the dorsal horn ganglion are there, that they are responsible for hyperalgesia, and we have to break that. Ketamine is an NMDA receptor blocker, so we have to break that chain. Once the memory of the nerve is gone, the nerve has remembered the pain stimulus. Once that is gone, the pain stimulus, allodynia and hyper responsiveness all comes to normal. So this is a good option. Then there are some myths. Let us revise. What are the myths and what are the facts? Many of us think that fibromyalgia is due to psychological problem. It is all in the patient's head. This is not true. Actually, fibromyalgia is a disease of second order neurons hyperexcitability. Then fibromyalgia is a disease of muscle, joints and connective tissue. No, fibromyalgia is not a musculoskeletal disorder, rather it is due to central sensitization. Then fibromyalgia is a wastebasket diagnosis. Physicians use this diagnosis when they cannot find any cause. This is also not true. Actually, there is specific guidelines set by the American College of Rheumatology, and it helps in establishing definite diagnosis of fibromyalgia. There is no treatment for fibromyalgia, and hence nothing can be done. There are numerous treatment modalities which are having good evidence in favor of successful treatment of fibromyalgia if given with a multidisciplinary approach. Many times we need our psychiatrist fellow friend or clinical psychologist friend. That is very important. Sometimes sports medicine people are also useful. They train, physiotherapists are important. They train the isomeric muscle strengthening. Thank you.
Thank you, sir. Thank you, sir, for a very clear, practical and enlightening presentation. So we'll move forward with the first session. I request Dr. Rajiv Pandey, sir, Dr. Wijahat Karim, sir, to please come on the stage. The format will be same. The first question will be from my left side. The second question will be from my right side. Those who knew the answer, just raise your hand. Our president, past president, will choose the candidate who will answer the question. आंसर्स थोड़े से ट्रिकी हैं, लेकिन मुझे लगता है जिन लोगों ने ध्यान से सुना है उनके लिए बहुत आसान होगा. जस्ट यू हैव टू रेज योर हैंड.
ये लाइट थोड़ा कम करना पड़ेगा. लाइट कम कर दीजिए थोड़ा लाइट. हाँ.
So question 1 is, all of the following can be symptom of fibromyalgia except stiffness, fatigue, short-term memory loss, or is it none of that above? Just raise your hand. Sir, आपको select करना please. अरे आपको select.
Dr. Surheeta. Dr. Surheeta.
D. Nota.
D. None of the above.
Right answer.
That's the right answer. Big applause for Dr. Surheeta ma'am. सुरीता मैम आज हम लोग की होस्ट भी हैं. एक बार मैं फिर से चाहूँगा उनके लिए जोरदार तालियां हो जाए. और हमारी न्यूली इलेक्टेड वाइस प्रेसिडेंट भी हैं मेडिकल एसोसिएशन के NHA से. आपको बहुत बहुत शुभकामनाएं मैम. तो हम लोग नेक्स्ट क्वेश्चन मूव करेंगे. दिस विल बी फ्रॉम राइट साइड. विच ऑफ द फॉलोइंग इज नॉट फाउंड इन फाइब्रोमाइल्जिया? Elevated level of glutamate, elevated level of substance P, low levels of endogenous opioids, or is it low level of serotonin? Just raise your hand. Dr. Sanjeev.
Sanjeev.
C. Low level of endogenous opioids. That's the right answer.
Right answer.
A big round of applause for Dr. Sanjeev. बहुत ध्यान से सुना है डॉक्टर संजीव ने।
मैं भी बोलना चाह रहा हूँ।
नहीं सर आपको सेलेक्ट इसलिए मैंने बैठाया है। So the third question will be from my left side. The following drugs are approved by FDA in the management of fibromyalgia except pregabalin, duloxetine, milnacipran or buprenorphine. Just raise your hand. Dr. Rita ma'am.
Buprenorphine.
Buprenorphine?
Yes, right answer.
Buprenorphine is the right answer. Big applause for Dr. Rita. कुछ बताना चाहेंगे इसके बारे में? मिलर सप्रिन और ये सब कुछ इसके बारे में एक बार इलस्ट्रेट करना।
Buprenorphine is not approved and even not used. It is an opioid derivative. That's why we discussed that opioid are not very useful. And buprenorphine has another very bad side effect, that is long-term respiratory depression. So even in anesthesia and acute pain management, we have left using buprenorphine. This is not a good option. Pregabalin, we all know, pregabalin is anti-epileptic actually, but it is very useful in this neuropathic pain and all. Duloxetine is SNRI, serotonin noradrenaline reuptake inhibitor. This is also very good, and this has the best evidence for management of fibromyalgia. Milnacipran is another SNRI. This is also very good, and this is available in the market.
Next.
The next
Fourth question will be from my right side. Allodynia is due to hyperexcitability of first order neuron, hyperexcitability of frontal cortex, inflammation of the muscles, tendons and ligaments, or is it option D, hyperexcitability of the second order neurons? Dr. Shalin sir.
D, hyperexcitability second order
neuron. Second order neurons, that's the right answer. A big round of applause for Dr. Shalin sir.
Next question.
So last question, anyone can answer. Following may be associated with fibromyalgia except IBS, vestibular disorders, hyperventilation, or is it none of them? Just raise your hand.
Dr. Shahi.
Dr. Shahi. D, Nota. Nota, na?
None of the above? That's the right answer. A big round of applause. Thank you so much. Now we will take a few questions from the audience, if any, regarding fibromyalgia. You can share your experience as well.
एक क्वेश्चन है मेरा,
जी,
जो आपने बताया कि सेकेंड ऑर्डर न्यूरॉन की हाइपर एक्साइटेबिलिटी है, तो what is the thing which is causing hyper excitability of the second order neuron? First question. And the second question is, कितने दिन में रिस्पॉन्स आता है? क्या ये लाइफ लॉन्ग ट्रीटमेंट है?
Answer to the first question. Substance P is mainly responsible. Substance P and glutamate. Glutamate आप देखेंगे बहुत सारे जो प्रिजर्वेटिव्स हैं, फूड प्रिजर्वेटिव्स, आजकल पैक्ड फूड खाने का हम लोग का आदत बिगड़ गया है, तो उसमें आप कभी रात को पार्टी में जाइए और बाहर के मसाले वसाले वो यूज़ किए, खाना खाइए, सुबह आप उठ के देखिए मॉर्निंग स्टिफनेस रहेगा, मॉर्निंग स्टिफनेस होता है, आलस होगा, सुबह उठने का मन नहीं करेगा। तो ग्लूटामेट इज़ वेरी इंपॉर्टेंट। ग्लूटामेट ही जो है वो कैल्शियम इन्फ्लक्स को बढ़ा देता है, सेकेंड ऑर्डर न्यूरॉन में कैल्शियम इन्फ्लक्स को बढ़ाता है और उससे हाइपर एक्साइटेबिलिटी होती है। और दूसरा सब्सटेंस पी भी सेम रोल है उसका भी, इसलिए हम लोग NMDA रिसेप्टर जो ब्लॉक करते हैं तो उससे ये कुछ हद तक रुक जाता है, कैल्शियम इन्फ्लक्स को हम ब्लॉक कर देते हैं। द सेकेंड क्वेश्चन इज रिस्पॉन्स एक्चुअली स्टार्ट्स टू कम इन 3 to 4 वीक्स। 3 to 4 वीक में पेशेंट कहता है कि सब पहले से बेटर है। तो सेकेंड विजिट में जब पेशेंट आता है तो मैं उनसे ये पूछता हूँ कि पहले अगर फर्स्ट विजिट में आपका पेन 100 था या वट एवर प्रॉब्लम इट वाज 100, तो अभी आप क्या स्कोर देंगे उसको? बोलता है साहब 60 है या 40 है या 50 है, जो भी बोलता है। तो उससे एक मोटा मोटी हम लोग को असेसमेंट हो जाता है कि आगे फिर और दवा बढ़ाना है, कंटिन्यू करना है, कम करना है, क्या करना है। और यूजुअली इन 3 months 12 weeks the patient comes happily and claims that pain is only 10 to 20%. तब मैं उनको बताता हूँ कि ये 10 to 20% के साथ रहने की आप आदत डाल लीजिए, एक्सरसाइज करते रहिए, लाइफस्टाइल मॉडिफिकेशन को कंटिन्यू करिए और ठीक रहेगा। 100% ख़त्म नहीं होगा। बाकी आपको अपने से एफर्ट करते रहना है। जो भी चीज़ें आपको 3 महीने के अंदर बताई गई हैं वो कंटिन्यू करना है, दवा को बंद करना है। तो दवा धीरे धीरे हम लोग टेपर करके बंद कर देते हैं नेक्स्ट 1 to 2 मंथ्स में। डाइटरी मॉडिफिकेशंस, एक तो ग्लूटामेट फ्री खाना खाएं, ग्लूटेन, ग्लूटामेट ये सब नुकसानदेह हैं उसमें।
रोटी बंद करते हैं,
रोटी बंद कर सकते हैं, अच्छा है, रोटी बंद करना ग्लूटेन है। और ग्लूटामेट सबसे इंपॉर्टेंट है, जो MSG होता है मोनोसोडियम ग्लूटामेट, तो मोस्ट ऑफ द प्रिजर्वेटिव्स में वो रहता है। हम लोग आजकल देखते हैं एक मसाला हमेशा हलवाई बोलता है हम लोग को अजीनोमोटो, अजीनोमोटो मोनोसोडियम ग्लूटामेट है और उससे खाना टेस्टी बनता है, सब्जी टेस्टी बनता है, सब में डालते हैं। हम लोग रेस्टोरेंट में, होटल में जहाँ भी खाना खाते हैं सब में अजीनोमोटो डाला जाता है। ऑल्दो कार्सिनोजेनिक भी है, तो ऑल्दो सरकार ने उसको अप्रूव किया है, परमिट किया है एक परमिसिबल लेवल तक, लेकिन वो परमिसिबल लेवल तक ही यूज़ कर रहे हैं या ज़्यादा यूज़ कर रहे हैं, हम मॉनिटर करने नहीं जा रहे हैं। और कभी कभार खाते हैं तो ठीक है, लेकिन अगर रेगुलर बेसिस पे हम खा रहे हैं ये खाने, तो इससे तो ग्लूटामेट थोड़ा थोड़ा करके एक्यूमुलेट होगा और वो प्रॉब्लम करेगा। इसलिए जहाँ तक हो सके पैक्ड फूड और बाहर के खाने, रेस्टोरेंट वगैरह के खाने जो चटपटे हैं, स्विगी और जोमेटो वाले, उनको हम तब तक ना खाएं जब तक बहुत इमरजेंसी ना हो, उसको अवॉइड करें।
ये आपके कहने का मतलब फाइब्रोमाइल्जिया इज इडियोपैथिक और नॉन इडियोपैथिक?
इट्स नॉट इडियोपैथिक सर।
सर लाइफस्टाइल डिजीज कैसे?
लाइफस्टाइल डिजीज खा सकते हैं। लाइफस्टाइल डिजीज डाइटरी, इसमें डाइटरी हैबिट, आपका लाइफस्टाइल, आपकी साइकोलॉजी, सबका कंट्रीब्यूशन
जो
है।
बैड हैबिट्स हैं, जो खान पान और
हाँ, इसके जो प्रेडिस्पोजिंग फैक्टर्स हैं उसमें ये भी है, चाइल्डहुड ट्रॉमा, साइकोलॉजिकल और फिजिकल ट्रॉमा।
मतलब ये कॉजेज हैं या इडियोपैथिक इसका कोई कॉज?
नहीं, रिस्क फैक्टर्स हैं, रिस्क फैक्टर्स हैं, रिस्क फैक्टर्स कह सकते हैं सर।
भी कह सकते हैं।
इडियोपैथिक
मे बी जी। वो ग्लूटामेट नहीं, CSF में देखते हैं मैम। CSF में लेवल 3 टाइम्स रेज रहता है ज़्यादातर फाइब्रोमाइल्जिया पेशेंट में। CSF में ग्लूटामेट और सब्सटेंस P बढ़ा रहेगा और प्लेटलेट्स में सेरोटोनिन लेवल घटा रहता है। सेरोटोनिन का जो सिंथेसिस है, सेरोटोनिन ज़्यादातर सिंथेसिस होता है, अप टू 80% सिंथेसिस होता है हमारे गट में। हम लोग को ये कंसेप्ट है कि ब्रेन में सिंथेसिस होता है, लेकिन ब्रेन में सिर्फ 10 to 20% ही सिंथेसिस होता है। 80% 80 to 90% सेरोटोनिन सिंथेसाइज इन आवर गट। सो और गट हेल्थ इज़ वेरी इंपॉर्टेंट। गट हेल्थ, अगर आपका पेट ठीक है, आयुर्वेद वाले डॉक्टर हमेशा कहते हैं कि सारी बीमारी का जड़ पेट है। ये बात कुछ हद तक सही है फाइब्रोमाइल्जिया में। अगर आपका गट हेल्थ ठीक है, सेरोटोनिन की सिंथेसिस अच्छी है, तो आपको ये सब चीज़ें प्रेसिपिटेट होने के चांसेस कम हैं।
सेरोटोनिन तो योगा से
बढ़ता है।
हाँ,
योगा, मेडिटेशन, एक्सरसाइज, प्लेइंग,
जो सिंपल सी कार्डियो एक्सरसाइज,
हाँ कार्डियो एक्सरसाइज, हाँ साइकिलिंग, स्विमिंग, कुछ भी करें, हाँ डेफिनेटली हेल्प करते हैं।
सो एनी अदर क्वेश्चन?
जी मैम।
एक डाइट चार्ट आप दे दीजिए, उसी को हम लोग फॉलो करें, बड़ा मुश्किल है।
वो तो मल्टी डिसिप्लिनरी अप्रोच हमारा डाइटिशियन दे देगा ना आपको। दिस इज अ मल्टी डिसिप्लिनरी अप्रोच है, डाइटिशियन को भी रोजगार देना है।
एक आपने फिब्रो वो बेंजीन कुछ बताया था आपने, क्योंकि ज्यादा जिसको पेन है उसके लिए आपने ऑफर किया।
हाँ,
तो
हाँ,
क्या है ड्रग, किस ब्रांड नेम से, कितनी डोजेज में, क्या कैसे प्रिस्क्राइब?
एक्चुअली वो सेंट्रल मसल रिलैक्सेंट है, इसलिए बहुत उसका यूज़ नहीं है। उसका यूज़ तब है जब बहुत ज़्यादा स्टिफनेस है, स्पास्टिसिटी है, स्टिफनेस है। साइक्लोबेंजाप्रिन वो आता है, फ्लेक्साबेंज नाम से एक आता है, फ्लेक्साबेंज, साइक्लोबेंजाप्रिन प्लस पैरासीटामोल के साथ आता है।
अच्छा, फ्लेक्सबेंज ऑइंटमेंट भी होता है उसमें?
हाँ, फ्लेक्साबेंज ऑइंटमेंट भी होता है, वही।
ये आपने जो जाइलोकेन इन्फिल्ट्रेशन जो बताया,
जी,
ये तो फर्स्ट ऑर्डर न्यूरॉन्स को ब्लॉक करते हैं, क्या करते हैं?
लीडोकेन जो
नहीं, वो
फाइब्रस
बैंड्स में, मसल में कहीं फाइब्रस बैंड को ट्रिगर पॉइंट्स बन जाएंगे। पेशेंट आएगा, यहाँ कंप्लेन, यहाँ दबाने से दर्द हो रहा है, यहाँ दबाने से दर्द हो रहा है, तो ट्रिगर पॉइंट्स में आप 2 काम कर सकते हैं। या तो हाइड्रो डिसेक्शन करिए 5% एक्सट्रोज के साथ, अल्ट्रासाउंड गाइडेड, उसमें चारों तरफ से इन्फिल्ट्रेट कर देंगे तो वो जो चिपका हुआ है वो हट जाता है।
इस पेज में तो पहले जैसे हम लोगों को फाइब्रोमायोसाइटिस जैसे
हाँ, तो
कॉर्टिसोन यूज करते थे तो बहुत रिलीफ मिलता
कॉर्टिसोन से सर रिलीफ मिलता है, इन्फ्लेमेशन खत्म हो जाता है, लेकिन वो क्या है कि फिर मसल फाइबर्स के टीयर करने में का डर रहता है बाद में, तो इसलिए कॉर्टिसोन को इंट्रामस्कुलर लगाना थोड़ा ठीक नहीं होता है। और बेटर है कि आप उसके अराउंड दें और हाइड्रोकॉर्टिसोन ये 5% एक्सट्रोज दे दें, उससे हाइड्रोडिसेक्शन हो जाता है। जाइलोकेन भी दे सकते हैं, जाइलोकेन से क्या है कि लोकल वो जो पेन का साइकिल है वो ब्रेक हो जाता है। तो ये एसोसिएटेड सिम्टम्स रहते हैं कभी कभी पेशेंट्स में, ट्रिगर पॉइंट्स रहते हैं जगह जगह, तो ट्रिगर पॉइंट्स में आप दे सकते हैं। हाँ, इट शुड बी डन अंडर सुपरविजन ऑफ ए पेन फिजिशियन। ओनली पेन फिजिशियंस कैन डू दैट, एनेस्थेटिस्ट।
So once again, a big round of applause for Dr. Santosh Tiwary, sir. Excellent session, excellent discussion, excellent quiz. Thank you.